Good afternoon, everyone. I'm Lizzie Minton, and Camie Tomlinson is here as well, like Elizabeth said. So we'll go over the learning objectives, I think, first for this session. Oh, we'll do introductions first. Sorry.
Okay.
Sorry, Camie. So Lizzie Minton, I am a program manager for screening and assessment. I work with University of Louisville and Kentucky's Department for Community-Based Services on screening and assessment. I've been doing this work in training, implementing the CANs in the state of Kentucky since 2016. So Camie, you should introduce yourself.
Yeah. So my name is Camie Tomlinson. I am an assistant professor at the University of Louisville School of Social Work and Family Science. Kind of broadly, my research focuses on the mental health of youth involved with the child welfare system. And so I've gotten looped in with Lizzie and our team here at U of L to work on CANs data.
All right, so we're excited to share some of what we've learned with you today. If we go through the next slide, we don't have anything to disclose, financial relationships, and then the learning objectives. So after the session, you should be able to describe the significance of CANs assessments in child welfare and behavioral health systems, summarize how CANs scores change longitudinally for youth in out-of-home care, and discuss the socio-demographic factors that may predict improvement in functioning among youth in out-of-home care. So before we get to the really exciting part of the presentation, I thought it would be helpful to just add a little bit of context to how the CANs is used in Kentucky. We began our CANs implementation in Kentucky in 2014 as part of a grant to implement a statewide standardized screening and assessment process. So we developed the Kentucky version of the CANs and trained all of our behavioral health providers on the use of the tool. We do ongoing trainings to support those providers. The CANs is completed by behavioral health providers statewide who provide those services to youth with child welfare involvement. We also have a screening process in place so that when a youth enters into the out-of-home care system, their child welfare worker completes a screener based on the youth's age to determine if they need further assessment or evaluation by a licensed behavioral health provider. And we use the CANs as the assessment tool, and our original implementation focused only on youth who were entering into out-of-home care, and we've since expanded the process to include youth who receive in-home services from the Child Welfare Agency, and that just went into place about a year ago. In our process, the initial CAN should be completed by that behavioral health provider within 30 days of referral or placement and updated every 90 days. We also have built an interface between our SACWIS, or our Child Welfare Information System, and the web-based application that providers use for the CANs. So a CAN summary report is automatically returned to the child welfare worker to assist in information sharing and case planning. And just of note, the CANs used in this analysis are all for youth that have been in out-of-home care. So we haven't begun yet to look at all of the data for youth that are receiving in-home services from the Kentucky Child Welfare System. So, all right, I think that's it. I'll pass it to Camie.
Okay, not to rehash what Lizzie already said, but the data that we are focusing on, or that we used in our analysis that we'll present today, ranged from 2016 to 2022. We examined each of the 6 CANs domains separately in our analyses. And like Lizzie said, when youth entered or were referred into out-of-home care, they had their initial CANs and then assessments every 90 days. And so we used the first 5 time points available to us. And so we were able to look at change in CAN scores over a 12-month period. And we did this by using latent growth curve modeling, which allowed us to create an estimate of an average trajectory for each of the 6 CANS domains based on youth's individual starting points, as well as their individual rate of change over time. And we actually split that into 2 separate slopes. So we looked at the first 6 months and then from 6 months to 12 months. So we have 2 slopes in our analysis, which made this quite fun. And so we looked at this analysis in 2 stages. The first stage was just to establish that average trajectory for each of the 6 domains. And then in the next step, we plugged in our sociodemographic variables to see if those variables predicted how these scores changed over time. So the first set of slides will just go through that step 1. So this will show the average trajectory for each of the domains. And so we'll start with our risk behavior domains. One thing to point out as we kind of look at the trajectory here on each of the slides is to keep in mind the range, which is also at the top of the slide. The range was quite broad for each of these trajectories. So for example, for risk behavior, scores ranged in our sample from anywhere from 0 to 39. The means tended to be on the lower end of the scale, which means our youth have less high risk. That I put that in a poor way, but higher scores here indicate greater risk in each of these domains. And so the means tended to be lower. So more youth are falling on the low end of the scale. We have a handful of youth, at the upper end of the range. But what's shown here on this slide for risk behaviors is that on average, youth started with a risk behavior score of 2.6. In the first 6 months, they actually improved in this particular domain. That slope was significant, and that's why that line is solid. But then from month 6 to 12, there was not a significant change in risk behavior scores. You can see that that line kind of flattens, and that indicates that their risk behaviors in those 6-month period kind of stabilized. And so that's the risk behaviors trajectory. We see a similar pattern for strengths. And so on average, youth had an initial score of 15. And in that first 6-month period, they improved in their strengths domain. And then those scores stabilized between months 6 and 12. For life functioning, it's again a repeat of the same average trajectory shape in terms of youth starting with an average score of 9 here with a total range ranging from 0 to 45. Within the first 6 months, youth improved in their life functioning scores, and then those scores stabilized once again between months 6 and 12. Again, for behavioral emotional needs, youth on average started with a score of around 7.75, significantly improved in that first 6-month period, and then those scores stabilized once again between months 6 and 12. For the cultural factors, we see a repeat again, improvement in the first 6 months and then stabilization. Caregiver needs and resources, we finally found a deviation from that pattern, switching from a focus on youth's needs to caregiver needs. Here, caregivers' needs tended to improve across the whole 12 months. There was a little bit of a steeper improvement in the first 6 months, but they did the change from month 6 to 12 was a significant improvement still, which again is a deviation from the pattern when we are looking at caregivers versus youth. And so to just summarize, over time, our results suggest that youth on average improved most noticeably during those first 6 months. And then the rate of improvement stabilized between months 6 and 12. except for that caregiver needs and resources domain, in which they continued to improve in that time frame. So moving forward to kind of focus most of our time on these sociodemographic predictors, we specifically looked at these particular variables. We looked at binary gender, so male versus female. We looked at age and out-of-home care. We treated these as continuous variables. So we looked at plus and minus 1 standard deviation away from the mean, so the average age and the average number of months in out-of-home care during the current episode. And so we'll refer to this as like older youth versus younger youth, and longer time in out-of-home care versus shorter time in out-of-home care. And then when we examined differences across racial ethnic groups, we used white youth as our reference group, and we compared against Black, Hispanic, and multiracial youth. So I'll start by saying there's a lot of information on each of the upcoming slides, and I'll kind of break down this first one so you kind of know where to look for specific information. The first set of bullets at the top on the right talk about how the sociodemographic variables predict the initial level of each of the domains. And so, for example, for risk behaviors, all sociodemographic factors were significantly associated with where youth started at. So in this case, males, older youth, youth in out-of-home care for longer periods, Black youth, and multiracial youth had higher starting points compared to their counterparts. So females, younger youth, youth in out-of-home care for shorter periods, and white youth. The second set of bullets show how these sociodemographic factors predicted rate of change over time. And so each of the bolded results are what's shown in the figure on the left. So on this slide, we see that older youth in blue tended to start higher than younger youth in gray. But these older youth tended to improve in their risk behavior scores at a faster rate compared to younger youth in that first 6-month period. But then the rate of change stabilized for all youth in the last 6-month period, and that's represented by those dashed lines. You can see those lines become a little bit more parallel, so their rate of change did not significantly differ between older and younger youth. So moving on to the strengths domain, we see a similar pattern in terms of predicting where youth start at. So again, males, older youth, youth in out-of-home care for longer, had less strengths in comparison to females, younger youth, and youth in out-of-home care for shorter periods. We start to see this interesting trend regarding Hispanic youth. Here for strengths, Hispanic youth had more identified strengths to start with compared to white youth. In terms of how our sociodemographic variables predicted change over time, age, length of time in out-of-home care, and race were significant. Here on this particular slide, we start by kind of dissecting age a bit. So in the first 6 months, older youth scores in blue improved at a faster rate than younger youth scores in gray. But between months 6 and 12, older youth scores started to improve at a slower rate compared to younger youth. So the blue line kind of stabilizes while the gray line continues to decrease or improve, is the way you would interpret this one. Oh, sorry, I had set it up so that I could show you the 6-month periods. Then moving on to length of time in out-of-home care, the figure depicts that in the first 6 months where the line is solid, youth with shorter stays in out-of-home care, so the gray line, improved at a faster rate compared to youth who had longer stays in out-of-home care. But there were no differences between these groups in months 6 to 12. For race, the only significant difference between groups occurred between Black youth and white youth, and it only occurred in the months between months 6 and 12. So here, Black youth, represented by the orange line, improved at a faster rate compared to white youth. Our next domain was the life functioning domain. Once again, all of our socio-demographic factors predicted where youth started. So males, older youth, youth in out-of-home care for longer periods, and multiracial youth had higher initial levels of life functioning in comparison to their counterparts. And then Hispanic youth had lower initial levels compared to white youth. In terms of rate of change over time, the figure on this slide depicts that older youth, which are represented by blue, the blue line, improved at a faster rate compared to younger youth. In looking at how these trajectories differ based on binary gender, in the first 6 months, males, which are the orange line, started at a higher level, but they also improved at a faster rate compared to females, which is the blue line. And lastly, this figure shows that not only did Hispanic youth start at a lower risk level in terms of life functioning than white youth, between months 12, Hispanic youth improved in terms of their life functioning at a faster rate than white youth. So in the behavioral and emotional needs domain, we see a repeated pattern in terms of socio-demographic characteristics predicting the starting point. So once again, males, older youth, and youth in out-of-home care for longer periods, as well as multiracial youth, had higher levels of need in this particular domain at the starting point. Hispanic youth, in contrast, had lower initial levels or lower levels of need in this particular domain compared to white youth. For rate of change over time, gender, age, and race were significant predictors. On this slide, we look at binary gender in particular. So females, which is the blue line, started with lower risk than males, but in the first 6 months, females' behavioral and emotional needs risk increased at a faster rate compared to males. But their rate of change kind of stabilized and didn't differ between male and female between months 6 and 12. Similarly, younger youth, the gray line here on this slide, started with a lower risk, but their risk increased faster in this first 6 months compared to older youth's risk. You can see that their risk kind of those dots become closer together at the 6-month mark in the middle compared to being further away at the starting point. And then there were no differences across kind of older versus younger youth between months 6 and 12. For Black and Hispanic youth between months 6 and 12, their behavioral and emotional needs risk improved at a faster rate than white youth's risk. But there were no differences in the first 6 months between those racial ethnic groups. And then our cultural factors domain, race ethnicity was the only significant predictor of where youth started, which makes sense based on this particular domain. The figure on this slide shows that white youth, which is the blue line at the bottom, had lower needs in this cultural factors domain compared to Black, Hispanic, and multiracial youth, which we would have expected. And then none of the socio-demographic factors predicted rate of change in cultural factors over time. And then in our final domain, caregiver needs, youth in care for longer had higher starting levels. And then once again, our Hispanic youth had lower levels of caregiver needs compared to white youth to start. Only race significantly predicted rate of change in caregiver needs over time. So on this slide, in the first 6 months, white youth scores in blue improved at a faster rate compared to Black youth scores in orange. And between months 6 and 12, Hispanic youth scores improved at a faster rate compared to white youth scores. So that was a lot. So to kind of summarize general trends across all of those domains, really males, older youth, and those with longer stays in out-of-home care had higher initial levels of risk behaviors, strengths, life functioning, and behavioral and emotional needs. Black and multiracial youth also had higher initial levels of needs in some domains, but we also saw this trend with Hispanic youth having lower initial levels of need in comparison to white youth. In terms of rate of change over time, males and older youth tended to improve at a faster rate in that first 6-month period. We saw that older youth's rate of improvement in strengths slowed down in comparison to younger youths in the strengths domain specifically. And then race ethnicity did not predict the rate of change in the first 6 months of treatment. But for Black and Hispanic youth, they tended to improve at a faster rate compared to white youth between months 6 and 12. And so something I'll point out here with the fact that males and older youth tended to improve at a faster rate, some of that might be because they started at a higher level. And so they kind of had more room for improvement, perhaps. And so that might be why we saw those improvement in those domains in particular. So some potential next steps. We have data, kind of more recent data, because this data ended in 2022. So it will be interesting to see if we see similar patterns in our data more recently. We're also interested in examining whether these trajectories might differ based on different treatment modalities, based on the type of treatment youth are receiving while in out-of-home care. And then I'm interested in, and we will look into whether there may be different underlying patterns in how youth are changing over time, and whether that might help us further identify youth who might be at higher risk for, these higher levels of risk in each of these domains. So we will leave time for questions that you all may have. Lizzie is the CANS expert, so I might defer some questions to Lizzie if it's a CANS question in particular. But I'm happy to talk analysis or findings. But we'd love to hear from you all if you all have questions about our presentation.
We've got one question in the chat.
Sometimes I have to do that too, Paul.
Yeah, I'm just going to need to look at it because I found myself thinking about what you were talking about as you were going on, and it was all very clear. I'm just slow.
It was a lot of data presented.
And the slides will be uploaded on the app after the conference is over. So.
Oh, perfect.
Yeah. Okay, we've got another couple questions coming in the chat. Any thoughts on looking at domains as the most prevalent items?
Lizzie, I might throw that question to you.
Yeah, I do think, I don't know that this is something that we've planned on doing, but I do think it would be interesting to look at the most commonly endorsed items, like within each domain, if there are certain items under, life functioning or under risk behaviors that we're seeing more frequently than others, as opposed to the domain as a whole. So digging a little bit deeper to the item level, not just the domain level, and seeing if there are any differences there.
Hi, this is Petra who asked the question. I was just wondering if you might expect the same similar patterns if you looked at items versus domain, because I mean, as you know, not every item in a domain is as highly endorsed as the next. So I was just wondering how that might affect what you found or.
Yeah, that's an interesting question and something that definitely can be explored through different analyses. To see, yeah, you're right. Like some of these domains include really interesting and sometimes like blurred items, I guess, almost like to see whether there might be to kind of group all of the items together and look at all the items under, all domains to see, are there items that are more frequently endorsed that might indicate maybe a different like title of need or different grouping of need than maybe how they are originally set up to be scored. That might help us identify, if youth are endorsing these, what patterns do we see down the line in terms of later need as well.
I see the question, Camie, that will be all you.
Yeah,
If you could account for random effects by utilizing nested data structures.
Results between fixed and random effect models. You considered a multi-level growth curve model. I have a very basic, I do have some multi-level modeling experience, and that would require like knowing where these youth are in terms of agency level data. So we would need to have that data from the state in terms of being able to group these youth within county, within agency to be able to do that. But that would be an interesting future analysis to be able to see, are there higher risks in certain counties or within agencies with certain characteristics, maybe based on like worker turnover, which also has some maybe has some influence in terms of our results and things like that. So yeah, so multi-level data analysis would be really interesting in terms of being able to further explain and further identify youth at greater risk or less risk in terms of this data.
I see the question about the faster rate of improvement in older youth be related to age as a confounding factor or natural phenomenon. Can you remind me what the age range was when we talked about older youth and younger youth?
Oh, sorry, Lizzie, say that one more time.
I can't remember what the age range when we talk about older youth versus younger youth.
Oh, yeah. I'm going to blank on that myself right now to not be able to pull that.
Because the can, I mean, these I think would have all of our probably 5+ cans. So kids 5 to 17 or 18. So what's the median age, and then one standard deviation above and below that. So I don't know if they're 13 years old, what the average or what that looks like. So.
Yeah. And I think that's something that I would be interested in exploring to kind of to this point of exploring whether, pulling out and doing maybe sub-analyses of different developmental periods in terms of their trajectories to see, we've kind of lumped all of these youth together just but across developmental stages to really look at this in terms of like adolescence, middle childhood, early like infancy and toddlerhood, to really break that down a little further to see are these trajectories the same or do they differ based on developmental period? Yeah, lots of future analyses, lots of things you can continue asking questions on for sure.
Yeah, I see Ken's question about parent caregiver needs and strengths impacted while child or youth was in out-of-home care. out of home treatment? Were there any family therapy or other community supports provided? So that is some data that we have, but was not included as part of this analysis. So that's somewhere we want to go, is to be able to, discuss or identify the treatment modalities, whether it was just individual or family therapy or supports, and then seeing that progress over time, what that looks like. I think we can assume, well, and that was one question I had, right, when at first looking at this, because what may have happened 6 or 9 months into a treatment episode, is the youth still engaged and involved with the family? Like I want to understand those stories better of the youth and their experiences, because maybe the family is no longer involved, or they don't have any information, and so that would change how we interpret that, right? So is it a true improvement over time, or is it a lack of engagement from the parent or caregiver, where the ratings might just, the clinician may have rated those a 0 because there's no evidence, or they don't have any information. So I think that is, like I enjoy like more case study, case review, to really explain what's happening there. Any other thoughts or questions?
Hi, Camie and Lizzie. This was a great presentation. I'm Melody. I'm really excited to see you looking at these trajectories over time. I'm a developmental psychologist, so I like to think about change, and I think your results are really interesting. I'm just curious if you have any thoughts about, what they mean, and what you're in terms of like intervention, prevention.
Yeah, I think it's definitely maybe heartening to see that there is some improvement, especially within that first 6 months of treatment and in care. The stabilization between months 6 and 12, like I think ideally we would want to continue to see improvement, but I think there's a lot of things that we didn't and weren't able to capture in this first analysis, in terms of, like Lizzie was saying, like kids coming and going and receiving treatment and then maybe not, and a lot of variables in terms of change in placement and whatnot. So that's something that I would be curious about in terms of, are there other factors that aren't being considered in terms of why we saw that stabilization or lack of improvement really between months 6 and 12? Or is that indicative of a place to really continue to intervene more in terms of providing that long-term improvement in these particular areas, to really focus in on months 6 to 12, or after they've been in care for a period.
Yeah, and I think just echoing what you said, Camie, also encouraging treatment providers to recognize the importance of that first 6 months of time in out-of-home care, right? So the early intervention, the early, interventions that we can put into place as kids are just coming into the system, that can have such a large impact. And then again, on the other end of also ensuring that, maybe we do need to highlight more in the second 6 months of treatment. And then Paul, I see your comment about kids in restrictive settings getting underrated. We have that same problem, right? So we train that we need to rate the youth, not the youth in care, not the youth in treatment. But when we created like a decision support tool around our QRTP process, we saw that there is a lot of underrating for kids in residential, which I think echoes how important or how interesting it might be if we were able to tie in placement type to the CANS ratings that we're seeing and those changes over time. Ken, they're all child welfare, not juvenile justice, all through child welfare system. Anything else? Camie, do you have anything to add?
No, I don't. This is giving me y'all's feedback has given me lots of thoughts for like future analyses though.
Mm-hmm. Yes, we definitely are highly focused on tool fidelity and accurately completing assessment, because we focus on, it feels solely on compliance for so long, that we're excited to be able to move beyond compliance and really looking at, that ensuring that people are using the tools in the ways that they're intended.
Okay, if people are going to be quiet, I'm going to ask the tough question, because I'm really glad to hear that we're not the only state that's struggling with this youth and care issue. So what do we do? I mean, it's good to know that we're not alone, but how do we make improvements in our training so that we're not getting kids coming out of hospitalization say, well, they don't even qualify to go into some services because they're doing so darn good.
Yeah, I think I would love to hear from other folks what they do. I know training, on a statewide level, we have hundreds of, maybe 1,000 clinicians that are trained across the state of Kentucky to complete CANs. And that when we see, something on such a wide scale, what is the most effective way to ensure, that the CANs are being completed in the way that they're intended? Of course, they have to, complete their recertification every year, but that doesn't mean that they're remembering how to rate, especially, youth that are in either residential or receiving those services.
Yeah. Sounds like we're all struggling with it. So I'm really open to what do we do to improve the accuracy of especially kids that are in restrictive settings so that we're not underrating the needs.
Yeah, and I wish I had an easy response, but like I said, I'd love to hear from other folks if they figured out how to address that consistently.
Sounds like Ken's got a thought. What do you think, Ken? You did a presentation on it.
Well, no, Lizzie and I beyond the certification. So, Dr. Minton, thank you so much for doing that. I learned a lot on how you all are doing the this. But I just, that's why I asked about where the referrals come from, because most systems of care will have multiple referrals or multiple agencies involved, and trying to get care coordination and being a former train the trainer and training in a statewide organization or using system of care and TCOM. It's a disagreement on ratings is important. That's the work. I remember doing one of the trainings, and what if a youth says they don't have a problem with substance, use or whatever it is. They don't see a problem, but the probation officer does, the family does, and child welfare, because maybe it's a safety concern. But I think it's okay to disagree, is what I was going to add. So it's not easy. And it's not I think a lot of people still view it as a checklist rather than a conversation. Another thing I learned from you was we were doing it, it's all about the conversation. So no solution, just identifying the challenges. Thanks, Paul. And what a great presentation. Wow.
Thank you, Ken.
Hi, my name is Joseph. I'm from the Pomona office. One of the things, kind of piggybacking off of this last statement here, it is, subjective for the worker, for the supervisor, when even between those two entities, the supervisor and the CSW, here in the Pomona office, I have heard, I guess, some discrepancies between them, where the CSW might want to rate it this way, but then the SCSW, after a conversation, wants to rate it a different way. So again, that kind of goes back to it being kind of subjective. So that kind of adds that element of difficulty and really trying to establish that consistency when it's even hard to do so within the same team. You know what I mean? Because they kind of view it differently as far as the rating system goes. So I just kind of wanted to add that piece to that.
Can I jump back in? I had a cup of coffee before coming. I should have warned everyone. I'm sorry. But that's an important piece to recognize that each group, like a child welfare person, is going to have a lens around safety. The same thing with juvenile justice mandating conditions of probation and parole. But doesn't it still have the conversations around what the needs are, not necessarily what will trigger continued involvement, but is this a need or not need? And having those binary areas of non-action versus action, a strength they already have or a need that they don't have versus a need they have very severely and that strength that we need to build. I'm going to mute myself manually.
Yeah, thanks. Mark, I see your comment too. Well, a couple of comments in the chat.
Yeah, I just think, this issue that you raised is one that exists in lots of systems. It is a struggle for teams to really think about their roles as in partnership with each other and working together, that they're using tools to communicate their agreement around action. This idea too that there's subjectivity, certainly there is, right? There's in all our fields, especially in person-centered work, there are going to be differences of opinions about how we move forward with families, between our teams, within our teams. But the goal of the tool is to communicate when we've built consensus, and then to use ones when we feel like there's a lack of consensus. And so sometimes in analysis too, a lot of times that when the tools are dichotomized for, reporting out action or inaction, it misses some of the nuance that's provided by that. There is one sometimes indicates that there's some lack of consensus on a team about whether there's a need or not, that we're actually going to start working on, or we're still contemplation about whether we're going to do our work. So it's just it's a good discussion, and certainly always going to be a challenge for implementing these tools within practice settings.
And can I piggyback, Mark, though, when there's a disagreement or a realization that this is something that family or youth doesn't necessarily want to work on at that moment, you could have it too. And Lizzie, Camie, in terms of that's something that can certainly be part of the rating, but it doesn't have to be worked on right away, as long as it's not a safety concern or putting themselves or others at harm, or get them kicked out of somewhere where they're receiving treatment.
Yeah, certainly. Yeah.
Great conversation.
I appreciate it. I always feel, when we talk about the work, the sense of not being alone, right? That people often have the same struggles, and the data can also tell the story. And so I think it's good to have the conversation and hopefully find some strategies to help resolve some of the issues, and I think also to say, like, we might just think that this is an explanation for some of the trends that we're seeing. It will be interesting with the more recent data from the last 2 years to see if these trends hold. Like Camie mentioned, as we've moved forward in practice, are we seeing any, any differences in some of these predictors? So.
I think Sophia's comment's really important. Is this better not be done by just the professionals? I hope we're having the conversation with the kid and the family. And if the kid is in a restrictive setting, and you say, so, what do you think about drug use and running away in your trauma response? And the kid may very well have a very different response. Not everything's fine than what the system partners and the family have. But yeah, I think having those discussions is pretty key. And I'm not convinced that they often happen like that.
Mm-hmm.
But Paul, that's a great point. That isn't it all about like someone sharing and being able to trust that information is not going to be used against them. And that's where, I was trying to find the blog, because the tcomconversation.org is a really amazing place where people have shared ideas. If you want to fall asleep, there's a great author by Ken McGill. But in terms of if I'm not going to share something, I don't have a relationship and I don't trust. And if I'm a parent, I'm not certainly going to share with people my substance misuse, and therefore my child might be out of my home for a longer period of time, versus someone who identifies there's a need that will provide some help and supports. So I think the level of trust and the purpose of behind what these tools are all about. Communometrics is an amazing assessment framework, and TCOM takes it to the next level. That's just I'll mute myself again.
Well, thank you all. I don't know if there are any other thoughts or questions